This presentation is not really so much scientific, I would say. So there is some point from how is the clinical trial, but it's more political, I would say. And for those of you that were in the global forum of last week, I do apologize because some of these slides you've seen it. And what I'm trying today is just up-to-dating you on how EMA is managing the orphan drugs and how is the situation with hemophilia. And I think in this society it's extremely important, each of you as a doctor, as a patient, to understand how is the regulation and whether we have to accept this regulation or we have to talk with them and trying to change some of them. So before to talk about orphan drugs, we need to understand the rare disorders. And the rare disorders are a group of very different diseases. And they have something in common, that is the low prevalence of these disorders. There are about 6,000 up to 8,000 rare disorders has been reported since now. And 80% of them, they have the genetic origin and they affect the children at a very early age. There is two definitions. In the US, a disease which affect less than 200,000 of the general population is defined as a rare disorder. And in the European countries, besides affecting fewer than 5 for 10,000 of inhabitants, a rare disorder needs to be shown that is life-threatening and chronically debilitating. What are the orphan drugs? Usually, due to the rarity of the diseases that I mentioned, the cost of developing and marketing of these products for diagnose, to treat and prevent are not covered by expected sales of the medicinal product under normal market conditions. And not having that benefit, usually they are orphan drugs. Therefore, in several jurisdictions, a specific legislation has been introduced to stimulate the development of drugs for a rare disorder, and that's the reason why we call them orphan drugs. And who is regulating the designation of orphan drugs? In Europe, this has started very late compared to other countries. In America, it was 17 years before, and in 2000, European Union started to have this regulation through a committee which is called Orphan Medicinal Product, and this committee is responsible to review the designation for application which is coming from a single person or from the company who intend to develop a drug for rare disorder, which is called orphan medicines. If we look on what has been done through this committee in the last 10 years, between 2000 to 2010, it's interesting that 684 drugs has been designated as orphan drugs, and of those, almost 10%, they can get the marketing approval. And of those, about 12% are in the field of hematology. And cancer drugs are the highest percent of this kind of designation. However, the European Orphan Drug Regulation is highly appreciated because its role in creating a favorable orphan drug development. There is some problem, and you can go through the literature and have a look, and there are some problems with the legislation, and there are some questions around that. Usually, when a drug has been designed as an orphan, there are incentive measures which could be like market exclusivity, setting up of tax credits and research aids, and simplification for a company and giving the advantage in the drug authorization procedure. So that means when we are designating to a company, to a drug, the nomination of an orphan drug, we are helping because we are believing that this drug is helping those rare patients that are not having any available product. What is the market exclusivity? Market exclusivity means that the company got this orphan designation target for 10 years is the unique a company that could produce that drug, and this time is changing from one area of the world to the other. For example, the shortest time is in Australia, about 5 years, up to Europe, which is the longest, 10 years for the adults and 12 years for the children. So that means in 10 years after granting of a marketing authorization, orphan medicinal products are benefiting from a market exclusivity. And during this period, as I mentioned, directly competitive similar products cannot be normally placed on the market. You have to pay attention on this as all laws. You have to understand exactly the words, competitive similar product. Then you have to be able to understand what is similar and what is not similar exactly. And the derogation from these articles are three situations. Consents of the original marketing authorization holder. This is a little bit difficult to get the consent from the first company that the second company could work on it. Inability of the original marketing authorization holder to supply sufficient quantity. And unfortunately, you know better than me, usually we discover this situation much later and when already the drug is not available. And this I see it a bit difficult. The third point is the second medicinal product is safer, is more effective, or otherwise clinically superior. And that is the case I want to bring your attention as a patient and as a physician. So you should know the drugs. You should know the structure of the drug and whether they are really safer and better. Do we have all that knowledge? We're going to see how much we know about the products. So market exclusivity and hemophilia. So we first of all should understand how the orphan designation could be made, and you need the conditions. The condition of the drug should be intended for the treatment, prevention, or diagnosis of a disease which is life-threatening. The prevalences we already explained, and there is no satisfactory method for diagnosis, prevention, and treatment. What about hemophilia? I think everybody in this room knows about the prevalence of this inherited coagulation disorder, and I would say this fits with the condition of the European Commission. And what about the condition, a clinical condition? Of course, our patient, if are not treated, that is a debilitating disease, so that condition is also fulfilled. But what about the drugs? Do we have anything to treat them? Of course we do. So the new drugs for hemophilia could be then qualified as orphan drugs, and if they are going to get the title of orphan drugs, could they benefit from economic incentive, including market exclusivity for 10 years? Is it correct to call them orphan drugs? And could market exclusivity in somehow to be dangerous for us, because that is creating a monopoly rather than market competition between the company to ensure the widest possible access at the most affordable price, especially in this new era of the treatment for hemophilia, but with all long-acting products that are coming to the market. For knowing that, you need to have two concepts, which are the key concepts. The significant benefit of the drug, you remember that was one of the conditions. And secondly was the definition of the similar product. So if satisfactory treatment is already existing, the sponsor should establish that the product will be of significant benefit. That means what we have now is good, but the drug company that is producing a novel drug is coming with something is much better, and we have to have the evidence for that. We know that hemophilia treatment has been improved, and you're going to see in the next session how much product we have. The fourth generation of the product up to 2010 really improved the life of the patient. But we know there are some problems, and the problems are frequent injection, immunogenicity, almost 1/3 of the patient. The cost of the product still is high, and still 2/3 of the patients in the world has no product at all. So that means we can be better. And for being better, that are the challenges where the drug companies and manufacturers are facing up, enhancing efficacy, trying to bring something is safer, with less immunogenicity, reducing, I hope, the cost, And in this way, probably having more possibility to treat more patients around the world. I'm not going through this one because I'm sure that Dr. John Grande would explain, but the extension of half-life is crucial. The infusion should be with a low frequency, and that could be with pegylation and different product with different pegylation. 20 kilodalton, 40 kilodalton has been used. FC fusion and albumin fusion reduced the reuptake, the amount of the recycling of the endothelial cell and increase the amount of the product in the circulation. And also these drugs, which are alternative therapeutic strategy like inhibition of antithrombin and especially bispecific antibody is extremely important, because with one infusion every month subcutaneously, if they are going to work, that could be the target treatment in the future. So these drugs seems to be interesting. We need to understand where they are, in which condition they are. And that is the most important things. You can see that there are already 4 companies working with long-acting factor VIII, and one of the product of Biogen that is already finished and completed a clinical study and has been presented to FDA in May 2013. For factor IX, we have 3 products, and in March 2013, Biogen has been presented this one to FDA, and there are some problems in this product which I'm sure you will have chance to talk about that, which is not available extensively, and only one long-acting recombinant factor VIIa is available for and completed the clinical study. So this is a big, important moment in the life of hemophilic patient. What means in a clinical practice and for the patient with hemophilia? So if the results are remaining as they are, 3 to 5 times increasing time for factor IX, that's significant. For factor VIII, the results are about 1.5 to 1.6, and for the recombinant factor VIIa, 2 to 3 times. That means the infusion of factor IX could significantly reduce by 2 times a week to once every week or even once every 2 weeks. Okay, so the condition of this better product is here. So I think the hemophilia community, all of us, we are very happy with this success. But there are no clear information yet and evidence which of these drugs result in a best clinical outcome in long term. And we need different approaches and competition. Is it correct to go with one of these drugs and say, okay, since you arrived earlier than others, you're going to get the market completely and the other drugs are not competing? I think we want all of them. We want the best them and we want the reduced price in them. And that was another condition, the similarity of the product. Are they same? So for knowing that, you need to understand the molecular structure of the protein. Since they are a little bit complicated, it's not easy, but you have to know that, and how there is mechanism of action of these therapeutic indications. These are different recombinant protein, different cells, different pegylation molecules. Some of them are 20, some of them are 40, some of them are combination of 20. So is albumin fusion, is FC fusion? I'm not sure they have the same immunogenicity. Günther was presenting the normal factor VIII and is more than 20 years, and we still don't understand the immunogenicity. Can you imagine with these new products? So I think we need to understand a little bit more on this product. So here is a position that European Haemophilia Consortium and Brian Mahoney with us brought to EHA during the meeting of June 2013, that orphan drug designation should not be used to hinder the development, licensing, and marketing of other products for the same condition which have demonstrably different protein modification or enhancement. And this is the condition that I think we have to keep in our mind and is our position. The second thing I think is very important for the patient to know how the regulatories are working now. And I'm not sure if someone from the regulatories is here because that needs a discussion. We have now, I showed you that one of the products of Biogen, Factor IX, is extremely interesting and is going to be in the market soon. But the adult patient in America, Canada, Australia, Japan, they can start to benefit from the product, but the patient with hemophilia in Europe cannot use that because there is a difference between the regulatories of FDA and EMA. And EMA is requiring to have the study in children. And that means after the adult study, we need to have 50 children that are using for 50 exposure day these drugs. And that means at least 2-3 years of delay. Because as I explained you, these are the products long-acting, and the time of infusion and the intervals are longer. So I think what we are trying is lobbying EMA, trying to convincing them that we might want to use the data of post-surveillance and understanding more instead of only exposure days at the initial part of the study. So I think harmonization between FDA and EMA is extremely important, and this discrepancy implies a severe disadvantage for European patients because they have to wait for data stemming from studies involving children, and to my opinion, there is no sense that adults need the children data to be treated. The lack of harmonization will increase the disparity in the treatment of patients with hemophilia, and European patients will not have access to new products at the same time as patients in the US and other regions of the world. And as regards the market exclusivity, hemophilia patients, to my opinion, are benefiting from a large number of plasma-derived and recombinant products, fortunately. However, further improvement could be very much appreciated for the extension of the half-life of product and reducing their immunogenicity. These products differ, as I reported, in structure, cDNA, vector, cells, ligand, or whatever you want to call, and could not be considered exactly the same. And orphan drug designation and market exclusivity should be considered only for those coagulation factors with no available product. And I heard from the company who produced factor V concentrate, which is the only and single product available for this patient, has been rejected for the designation as orphan drugs. And this is something, to my opinion, really not acceptable. So hemophilia doesn't need the orphan designation. Let's go to do it for the rare bleeding disorder and put the competition between the drug company to bring with the better drugs and cheaper prices if it's possible. And that is it. I hope that you now know what is happening in the EMA, and each of you is important for us in the future to convincing the regulatories that we need the drugs to come to the market easier. Thanks very much for your attention.